Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today's podcast is about voluntary assisted dying. This is the first of a two-part series.
Voluntary assisted dying has been a legally available end-of-life choice for dying Western Australians since July 2021. As we near our third anniversary with demand well beyond initial predictions and continues to grow, we're grateful to Rural Health West for offering us the opportunity to have a conversation today about what this means in practice, particularly for GPs caring for patients in regional Western Australia. My name is Alice Morison and I'm privileged to lead the WA Voluntary Assisted Dying Statewide Care Navigator service, and I'm joined today by Dr. Boo O'Brien and Dr. Sam Ognenis, GPs who have had varied experience both in supporting their patients at the end of their lives and as VAD practitioners. So Sam and Boo, I wonder if you might start with the burning question, which is always, who's eligible for access to voluntary assisted dying?
Thank you, Alice. The eligibility criteria in WA currently is someone needs to be 18 years old at least, a citizen of WA or permanent resident, and they have to have proof of residency in our state for longer than 12 months. They also have to have a diagnosis of at least one condition or disease that is advanced, progressive, and will cause death, and will, on the balance of probability, cause death within a period of 6 months, or in the case of neurodegenerative diseases or conditions, within 12 months. The patient has to have decision-making capacity and be acting voluntarily and without coercion, and the request for VAD has to be enduring.
Beautiful, thanks Boo. So I think it does essentially what it says on the wrapper, doesn't it? So yes. Voluntary assisted dying as a name was a really intentional choice in Western Australia. And so voluntary in that it's my choice for myself, no one can make it on my behalf. It's assisted in that I need the help of people to proceed through the process, particularly two doctors to do medical assessments like your good selves today. And I must be dying to be able to access it. It's not something that's available to people who are normally fit and well or don't have an illness or disease that is likely to cause their death in the near future.
Absolutely.
Perfect. We do get a lot of questions, and it's a great opportunity to do a little bit of myth busting here about the differences between legislation across states. And there are some key differences in Western Australia. We did a lot of learnings from our colleagues in Victoria when our law was drafted. And in Western Australia, any medical practitioner, including nurse practitioners, can actively raise voluntary assisted dying with a patient as part of a whole of end-of-life care conversation. So I must talk to my patient about all of their active treatment options and the likely outcomes of those, palliative care and the likely outcomes of those treatments, and VAD can be raised as an option for a person at the end of their lives. But patients are able to engage in all of those things throughout the process. I wonder, Sam, if you would talk a little bit about how that might be raised in practice. How might that come up with the patient that you're talking with?
Definitely. Thanks, Alice, and thanks to Rural Health West. So typically, there'll be a few ways that the patients might come to my attention or the attention of the team, the Care Navigator team with the VAD WA service. So for some patients, it's that they or their family member has an awareness of the program, and they raise it straight off the bat, and they come in asking for that, either from their usual GP, oncologist, cardiologist, whoever it might be that they're seeing, or it might be that they've gone to the VAD service and then have been forwarded on to a VAD practitioner who's done the training and is able to provide that care. I think exactly as you pointed out, it's really important to emphasise that when you're discussing the person's management options in their advanced disease, you can mention VAD under the law, but the law also requires you to incorporate that as part of a full discussion. So you can't just mention VAD and not anything else, but you also don't have to mention everything else without mentioning VAD. And people are often reassured by that fact that, as you're discussing, chemotherapy, radiotherapy, procedures, etc. You're mentioning obviously palliative care options. You're mentioning obviously what you can do at a GP level as well, and through the various services, allied health, chronic disease management, and you can mention the VAD process as part of that as well. And typically, I think most people most listeners would probably agree that people are fairly circumspect but also fairly practical when they have these advanced diseases, and often the question of VAD is on their mind at some stage during their disease process, or at least end of life is on their mind, certainly. And so sometimes, you raising it can help take a bit of a weight off that sort of elephant in the room, I suppose. But also it's important to emphasise that not everyone is interested, not everyone want that, and even if they have the information, that's certainly not for everyone. So to have that option mentioned, and the person can then lead from there, basically.
Beautiful, thanks Sam. And it's really important to know that sometimes the conversation is just a conversation. A patient can just seek information or talk to you about what VAD is and what it isn't, and may choose never to proceed. And even if they do choose to proceed, they may not be found to be eligible. And even if they are found to be eligible, they may not, in the end, choose to access voluntary assisted dying, because about 30% of people go the whole way through what is quite a complex legal process, have it available and choose never to use it. Just knowing that it's there is enough of a sense of relief and release for them. Boo, I wonder, has your experience been similar in that space? How would you go about raising it with patients that you're seeing?
Very similar, actually. I think initially with something like a cancer diagnosis, you are talking to the patient and supporting them around their actual active treatment, because often prognostication isn't immediate, because initially, unless they have straight away a very short prognosis, it's all about the treatment and you support them with that. And I find then gradually, you may need to see the patient and talk to them more, pointing them in the direction of palliative care when prognosis is seeming like this is going to end their lives rather than be curative, the cancer or the disease. And that's when, VADs I think can be introduced into the options that they may have, and they may choose to ask you more questions then at that stage. And certainly from the experience I've had in the last nearly 2 years is that patients are feel very much more supported when their GP is on board with them, and they feel sometimes it upsets them when they themselves have brought sometimes VAD up with their GPs, and it's caused discomfort because they value that relationship very much, and they've had that relationship for many years sometimes, and it's good for them to feel supported.
So Boo, that's really great to hear, and I think it's important to remember that one of the core tenets of the Act, one of the key principles that are written as part of our law, is about maintaining a person's therapeutic relationships with their treating teams, and the GP relationship is such an integral part of that. So if a patient has perhaps considered voluntary assisted dying and comes to you as their GP or to a doctor in any context and makes a clear and unambiguous request to you for your help to access voluntary assisted dying, I wonder if you'd walk us through the mandatory responsibilities in relation to receiving a first request.
When you receive a first request, there are, as you say, mandatory responsibilities, and that's one of them is that you have to accept or decline. And if you decline for whatever reason, you don't have the training or you have conscientious objection, you're a conscientious objector to it, you have to let the patient know then and there. And to put it simply, you need to accept or decline. And I think this is the part that a lot of GPs aren't aware of. And certainly, it's we as GPs, I think Sam and I both will agree on this, is that we're bombarded with new information every single day from every speciality. And it's just really difficult to keep on top of this. But the key thing is that it has to be done. This form has to be done, and you can access it online. As we spoke before, Alice, I think the good way of looking for it online is Google VAD. When it's bad, Google VAD. And you'll find the first response form. And that needs to be filled in whether you accept or decline the patient's request. Obviously, declining is totally up to you. You may not have the training, or you may not wish to, you may wish to support the patient alongside their journey, but not want to actually be their VAD doctor as such, or you might have a feeling of conscientious objection, which is fine as well. But regardless, that form has to be filled in. That's a statutory notification for the board. Then the other thing that you have to be aware of as a GP is that you do have to give them the approved information, and that can also be found online on the VAD site. I think that's really
they're definitely the key pieces. So making sure that you tell the patient that you either accept or refuse their first request, giving them that copy of the approved information for a person making a first request for voluntary assisted dying. We went for short, clear, touchy titles. Document in their medical records and notify the Voluntary Assisted Dying Board that a first request has been made to you, much like you do with infectious diseases. Sam, if you might talk to us a bit about the training. Boo mentioned that, a person may choose to accept a request if they have done the voluntary assisted dying training, and obviously both of you have done it. Hurrah for me. But I wonder if you might talk a little bit about what that was like.
The training is essentially a whole day session. There's options for rural practitioners in terms of supports for them to travel to Perth and do the training. And certainly from what I understand, there's doctors and nurse practitioners who've done the training purely to get the information, have the education and have the resources in order to feel more comfortable and confident, sort of as a CPD essentially, or to specifically help one patient that they has raised it with them. And then there's obviously people that are doing the training in order to be a VAD practitioner. And even within that, you've got, I know there's people that have done the training, and particularly if they're in a subspecialty, will majority of the time just be interested in doing the consulting practitioner role, which I'm sure we'll touch on in a second. But essentially, so not the person that does the initial review and paperwork and potentially the administration at the end, but more the person that does all the checks and balances, making sure that the person is eligible, fit, able to participate and meets all the criteria. So, for example, you might have a patient who has a neurological, neurodegenerative condition, and you're the coordinating practitioner, and then a neurologist might be the consulting practitioner. They may not feel comfortable to do those sorts of assessments on non-neurological patients, but certainly comfortable on those that do have neurological conditions. And so them having done the training means that they can actively participate with that. As I said, it's a day-long training, but with it's quite interactive. There's usually a small group of anywhere from sort of 6 to 15 kind of people in a room, and everyone's sort of asking questions as you go, so everyone's sort of on the same page and understanding. And it includes some reading, some online quiz things at the end, but also getting the direct contact information from the Care Navigator service, from the statewide pharmacy who provide the medications, and how that actually happens, and a lot of practical things about people's experiences. There's usually a person or 2 or 3 that are current VAD practitioners who can then share their experience and can give that advice and expertise.
And that connection and mentorship is so important in this space. So it's interesting to hear, Sam, that you chose to attend one of the face-to-face training days. So before getting access to the training, you do need to have your eligibility assessed. So it's an application that goes to the Department of Health, and it is only available to doctors who are at least 1 year post-specialist registration in most cases. And there's some things around minimum hours of practice, and certainly the Navigator service will help you if you have any questions in that space. The training can also be accessed on your own. You can do it online, and it's about 6 hours of online training that you can do in one chunk or in pieces. And thanks for the shout out about the Regional Access Support Scheme too, Sam. So you can also apply to the Navigator service if you work in regional WA to have some funding support for your time to complete the training. So if you are interested, please do reach out to the Care Navigator service for that one. So we've talked a lot so far about what VAD is, but I wonder if you might come back to what the GP's role might be. So maybe I don't have an interest in doing the training. I don't want to be a person's VAD practitioner, but I want to continue to be their GP to care and support them. Sam, I wonder if you might talk about what that might look like, what that GP could continue to do in caring and supporting their patient.
Absolutely. So as Boo pointed out originally, the GP is often the most important person in that team, no matter if the person's having active treatment with whichever specialty, hospital stays, scans, etc. That's the person that has that long-term relationship, that coordinator role, that understanding of the person, their family, etc. And can perhaps sometimes also be the translator, interpreter of some of the information that they might receive that might be confusing or complicated for the patient and their family. So that's all still very important part of it. And I guess to maybe bring some examples in, obviously de-identified, not confidential, but essentially, I've had patients who were in the process of they're going to be dying within the next couple of weeks. So the process has to happen now and quickly. And even in that circumstance, the GP might be involved in assisting with providing information, documents, having a chat on the phone, giving some support to the person and their family, prescribing other medications on their palliative care, for their palliative care requirements. But that's somewhat unusual, I would say. I think quite a few patients are in the process of dying over weeks, months, or in some cases they reach that 6-month threshold. We didn't think they would on the balance of probabilities, but they have. And certainly those people, there's minimal ongoing contact with the VAD practitioner that's required by the law. So there's certainly, I think it's good practice to make sure you're checking in and making sure things are moving smoothly, and the care navigators certainly facilitate that for us. But obviously in that time, the person still has their needs for medical care, for prescriptions, for referrals, for support, for all of those things that practically are needed, and a GP is well placed to help with that. But also, as I say, that support and an awareness of when the person might be deteriorating, and what that means in terms of when it might be appropriate to refer them to other services. And I suppose it's important to emphasise the WA Rural Palliative Care Network, and as I'm sure the listeners are all aware of, the regional palliative care services in each of the hubs that are either medical or nurse practitioner led, as well as the hospices in Albany, Bunbury and Geraldton. All these services are absolutely essential parts of all of this process, and you're best placed to know who might benefit from those and getting those patients referred. And often, as you said at the start, Alice, that may then become their ongoing care through a palliative care service, a hospice, and even if they've started the VAD process, potentially not actually utilising it in their end of life.
That's perfect, Sam, and I think it's a really important point when we're talking about VAD, and that this is never intended to be an island. VAD functions best when it's a choice alongside all of the person's other end-of-life care choices like palliative care. So perfect, thank you so much. But I wonder, patients often come to the Navigator service saying that they've written VAD in their AHD, and they've often had that conversation with their GPs. I wonder if you might talk a little bit about whether or not you can put VAD in your Advanced Health Directive.
Yes, I think this, the answer is no. The Advanced Health Directives allow people to make decisions for when they cannot make decisions themselves. And one of the key things about VAD is that the patient has to have capacity throughout the process, and this includes the time that they choose to have what we call it an administration visit, which is the visit that will end their life. So at that time of that visit, they have to know who we are and what they want. They have to be able to respond and say that they still want to have their lives ended by VAD at that time. And so really an Advanced Health Directive is not relevant in this case. And we're having ongoing discussions with patients about then, why it's not possible to have VAD with dementia for this reason.